All right. Well, good evening, everybody. Welcome to our 2024 Pediatric Epilepsy Conference. My name's Mary Laughlin, and I'm the Northeast Resource Coordinator for the Epilepsy Foundation, Eastern Pennsylvania. We have a wonderful program for you this evening. We will hear from our experts, Maura, McInerney, and also from Dr. Samuel Alperin about protecting the rights of students and epilepsy and mental health and epilepsy. So we have some housekeeping items. Your audio and video will be muted for the entirety of the conference. You'll have the opportunity to ask questions by the chat box below, and your questions will be asked of the speakers for each presentation. Now, you're not alone. Here at the EFEPA, we want you to know some of the stats to let you know you're not alone. There are 3.4 million people in the United States with epilepsy. 1/3 the number of people with epilepsy that have uncontrolled seizures. 1 in 26 people will develop epilepsy in their lifetime. 6 out of 10 number of people with epilepsy where the cause is unknown. And there's 110,000 number of people living with epilepsy in Eastern Pennsylvania alone. So we at the EFEPA are your local affiliate of the Epilepsy Foundation of America. So we serve 18 counties, Pennsylvania, and we're focused on education, support, and advocacy. We've been around for 50 years, and it's our pleasure to help you and your families. We have many wonderful programs. In case you're unaware of, we do seizure recognition and first aid trainings for families, for schools, for businesses, for EMTs, for first responders, for anyone that needs to know. We do monthly support groups. We have advocacy efforts where we go in and we help with different problems that you're having. We do community and awareness events. So we go to health fairs and we go to other places where we have awareness. We do educational conferences and webinars such as this. We do information and referrals. So we go into schools, we do INRs, we do IEPs, we do 504s, but we also help people that are trying to get disability or find a good neurologist in their area. We have youth, young adult, and adult services. We have programs for each of those. And we have retreats. We have a young adult retreat. We have an adult retreat, which are extra long weekends, which are fun, but you learn and you're meeting with other people that have seizures. And we also have Camp Achieve for children 8 to 17. And it's a whole week sleepaway camp in August at Camp Green Lane. So it's really good opportunity. If you have a child in that age group, please look into our camp. It's life-changing. And how you can get involved. You can raise awareness and share your story, volunteer and be an advocate for the foundation, invite the EFEPA to lead a seizure recognition and first aid training, attend a fundraiser for EFEPA events like our walk or our bowl-a-thon or any activities that we have. Visit our website, www.efepa.org. Follow us on social media, Facebook, Epilepsy Foundation Eastern PA, or Instagram and Twitter at EFEPA. So we have some upcoming events. We have a young adult retreat, April 25th to the 28th. That's at Camp Green Lane. It's right outside of Allentown, in Pennsylvania. We have a walk to end epilepsy, the Lehigh Valley, which is Saturday, June 8th from 9 until 12. It's at Upper Susquehanna Township Community Park in Bethlehem. We have a walk to end epilepsy in Philadelphia, Saturday, June 15th, 9 to 12 p.m. at Rose Tree Park in Media. Camp Achieve is August 11th to 16th at Camp Green Lane. And we have an adult wellness weekend, September 20th to 22nd at Deer Park Camp and Retreat Center in New Hope, Pennsylvania. So we'd like to thank our conference series sponsor. Tonight, Marinus is sponsoring this program for us. So thank you very much. And this is the conference schedule. So first we'll have Pediatric Epilepsy and Mental Health Screening, Diagnostics, Treatment by Dr. Samuel Alperin. Then we'll have a break, a 10-minute break, 7 to 7:10. And then we'll go into Protecting the Rights of Students with Epilepsy to Learn by Maura McInerney. So to start us off, Dr. Samuel Alperin is a child neurologist at CHOP. So Dr. Sam Alperin majored in neurobiology and behavior in college, and then did research in adult ADHD before going to medical school at Hofstra University, Northwell School of Medicine. He completed a child neurology residency at Cincinnati Children's Hospital, and currently he is attending child neurologist at CHOP, doing general neurology with a particular focus in neurodevelopmental disorders like autism and ADHD. So, Dr. Halpern, we're pleased to have you, and thank you for sharing your information with us. My pleasure to introduce Dr. Halpern.
Thank you, Mary.
You're welcome.
So let me know, obviously, if you guys can't hear me. And I apologize. My dog is chewing her bone right now, of course. So I apologize if you guys hear that in the background, but hopefully shouldn't bother us too much. So as Mary had said, I'm going to talk about mental health in children with epilepsy. I apologize for those of you who are adults with epilepsy or have loved ones who have adults with epilepsy. I won't be talking too much about that, although a lot of the similar ideas and thoughts hold true for those who have depression, anxiety, and ADHD in adults with epilepsy. Briefly, I'm going to review kind of the three main disorders. I'm not going to talk too much about autism or other psychiatric disorders like schizophrenia and psychosis. But so I'm going to review kind of the signs and symptoms and diagnosis for things like depression, anxiety, and then ADHD, and then review treatment. I can't imagine this is going to be news to some of you. I'm actually going to make this into, let's do that actually. All right. So about a quarter to almost a third of patients, of children, sorry, with epilepsy have diagnosis of anxiety, which is larger than the population for larger than the frequency in the general population, around 10 to 20%. Another third have depression in children with epilepsy, again higher than the general population, and almost 2/5 of patients with ADHD, with epilepsy, also have a comorbid diagnosis of ADHD, which is almost 3 times the amount of the general population. Unfortunately, there are higher rates of suicide in those who have both depression and epilepsy. Higher rates of mental health problems like anxiety and depression can cause increases in uncontrolled seizures. And similarly, uncontrolled seizures can cause higher rates of mental health problems. And so epilepsy is more common in those with ADHD, anxiety, and depression. And anxiety, depression, and ADHD, those who have those are also at higher risk for epilepsy. And so I think there is often a bidirectional connection between these mental health problems and epilepsy, and it's important to manage both simultaneously and not let one go, as it can make the other one worse. So first, we'll talk about some depression. In the grand scheme of things, per our kind of the psychiatry Bible, the diagnostic manual, the DSM, there are 9 classic symptoms of depression. The most important ones are the first two that you see on the left, and you have to have at least one of these, either depressed or irritable mood most of the day, nearly every day. And this can either be kind of a subjective report of somebody saying they feel sad or empty or other symptoms, or even an observation by a loved one who can describe that there has been a difference between before and after. The second necessary symptom, you can have either the first one or the second, and the second one is a decreased interest or pleasure in activities that the person or child used to enjoy before. And again, this can be subjective as well as observed. Then there are 7 symptoms that are not necessary, and these but are part of the diagnostic criteria. And these can include either increased or decreased sleep, feelings of guilt or worthlessness, fatigue and lack of energy, which is often known as anhedonia, poor concentration. There's at least a 5% weight change in either up or down, or at least a change in appetite, and psychomotor agitation or slowing. These psychomotor is just a fancy way of saying that the person is physically, motorically either agitated, kind of moving around a lot, or quite the opposite, slow moving and slower than their baseline. And again, this is more of an observation by others, and often and not a subjective feeling by the patient. And obviously, suicidality is one of the primary symptoms. As you can see, there are words that I highlighted, and one mnemonic that we learned back in med school, something called SIGICAPS, which is just an easy way to remember what are these symptoms, and basically they just fall into those 8 symptoms. And of course, depressed mood is the 9th symptom. In order to meet full criteria for major depressive episode, you need to have at least 5 of those 9 features, and these symptoms have to be there present for about 2 weeks at least, if not longer, and they need to be causing significant distress or impairment in either social interactions, school interactions, or other areas of functioning. And importantly, as with most things, should not be due to something else. As you can see there at the bottom, thyroid problems, diseases like Wilson's or lupus, or hematologic or blood disorders. There are other disorders that are similar. You can have dysthymia, you can have grief, adjustment disorder. These are kind of milder versions of the major depression. You have less of those symptoms and often can last longer, and usually, at least in the setting of grief and adjustment, are related to a specific incident. You can have bipolar disorder. That's folks who have depression plus mania, where they're doing things like not sleeping for days on end, shopping inappropriately, sexual activity that's inappropriate, etc. Or you can have anxiety, and these are all can present as depression, but it's important to rule those out, or at least consider them when someone is being worked up for depression. I highlighted significant distress or impairment because I think this is something that comes up and you'll see frequently throughout this discussion, because a lot of us will have lower levels of mood every so often, whether it's in the winter or something happened, but it really needs to be meet the threshold or be above and beyond the usual symptoms of low mood to actually cause impairment in the day-to-day functioning, whether it's at school, at home with parents and siblings, or with friends and other loved ones. We grade depression as per usual, as with most things in life, from mild to more severe, and not surprisingly, mild is just barely meeting that criteria of 5 or 6 symptoms. And again, these symptoms are distressing, but usually manageable, and family is sometimes making do with these symptoms, but it is causing impairment in the things we discussed earlier, school, friends, and family. But again, the child and the family is able to push through and maintain what are called ADLs, or skills of daily living, etc. Then there are more severe cases, so closer to 8 or 9 symptoms, and usually suicide is one of those. Again, this is distressing, but in this case, not just distressing, but also now becoming unmanageable, and there's marked impairment in different settings, usually more than one. And as you can imagine, there's a moderate stage where 6 to 8 symptoms, where overall a child is getting through, but again, manageable, maybe not manageable in all different areas of life, etc. And again, part of that is just question of helping us to grade it can help us understand how quickly does this child need to be seen? How quickly do we need to start medications or not medications? What are the next steps in terms of treatment? More severe cases, particularly for children, can cause declines in social school function. So kids' grades are starting to worsen and they're not functioning at their appropriate level. They start to have isolation from their friends, either at school or at home, and choose not to go out to do activities that they previously enjoyed. Often have non-specific physical symptoms, headaches, belly aches, dizziness, etc. And then very rarely, but possible, especially in the adolescent population, there's often symptoms of psychosis. So things like auditory, visual hallucination, seeing things or hearing things that aren't there, or paranoia, having delusions, symptoms of worry about people out to get the person, or that somebody's listening or going to harm them. And so these are less common, but again, important symptoms to think about when it comes to diagnosis of depression, etc. And unfortunately, untreated depression can cause increase in risky behaviors. So things like risky sexual behaviors, increase risk for things like substance use or abuse, and then obviously acting out at school and at home with oppositional symptoms, yelling, screaming at the family or teachers or siblings or friends, etc., getting into trouble, things that were not seen prior to onset of depression. I'm going to move on to anxiety, and I apologize. I'm giving kind of the overall lay of the land here, but obviously, if there's any questions, I'm happy to answer them. Anxiety is a bit broader than depression, and symptoms. There's kind of a more subtypes of anxiety, but anxiety, generally speaking, are things like excessive feelings of worry or nervousness in response to stress or uncertain situations. So these are the kids who every time you say, hey, we're going to the mall this weekend, or we're going to go to the doctor today, or next week, there is an over or excessive, out of proportion number of questions and worries and symptoms. And so, and again, going back to those somatic symptoms of kids who have anxiety related to school will often have stomach aches either in the morning or right before getting to school, or often in the middle of school, and work up from a doctor in terms of concerns about a GI symptoms or some GI disorder usually come up negative. Similarly with headaches, as you can imagine, I see lots of those, and often anxiety is a major contributor to headaches, and often is the anxiety is the thing that's the major part of the headaches, and really managing the headaches is really bettered by managing the anxiety. And again, this is causing clinically significant distress and impairment in function, meaning kids are not doing as well in school, or acting out in school, or not participating in afternoon after school activities like sports or practice or things like that, avoiding hanging out with friends, etc. Kids can appear restless and inattentive, can have difficulty with concentration. And I want you guys to remember that for kind of going forward as we talk about ADHD and some of those subtle differences. And it's something that the physician would discuss with you about. Okay, so the kid is presenting with inattention, but is that due to constant racing thoughts and worries, which is an anxiety, or something else that's more of a ADHD-driven phenomenon? Kids can have, as I mentioned earlier, outbursts of anger, of irritability, frequently crying, and having temper tantrums. And again, this is it's important to remember that this is happening as new for the child, and not a child who already has this diagnosis or has these symptoms prior to onset of anxiety. And anxiety can, as depression can present with internal symptoms as well as external symptoms. So internal symptoms are ones that we can kind of assume from looking looking from the outside, but really it's the patient, the child themselves are feeling things like they're withdrawing from activity. There's these vague symptoms of pain or somatic symptoms, somatic meaning things like you're feeling dizzy or lightheaded or numbness or tingling in the hands and feet. And then there's external symptoms, that what the child is actually doing physically to you and the things that are bothersome to the person who's bringing up these concerns. Things like they're really irritable, they're always arguing with me, they're always having tantrums, and they're having these behavioral outbursts. This is just not my child. Anxiety can fall into different buckets, and so you can have things like separation anxiety. So this is the child who really prefers not to leave the house, or kind of leave the side of their loved ones, their parents or their older siblings, etc. And there's a significant amount of distress. Not the kind of sixth grader who's about to start, sorry, the first grader, the 6-year-old who's about to start first grade and has a little bit of anxiety that first day. That is normal. But now it's getting to the point where this is second and third grade, and we're still avoiding school. We're still having all these symptoms of headaches or stomach aches, and truly they seem better on the weekends for some reason, but on the school days they really are present. Social phobia. This is more of worries about interaction with other people, and particularly at least in the setting of a pediatric patient, in the setting of a child, this needs to be fear or discomfort with age-appropriate social environment. So they don't want to go out to birthday parties. They don't want to hang out with other friends. When they meet other kids who are their own age, not just adults, because lots of kids have fears and anxiety of adults, as I see every single day in my clinic, but really with kids in their class or kids in their karate class, those kind of things. Specific phobias, things like animals, things like spiders or dogs, or thinking about airplanes or heights or other things like that. But again, to be clear, this isn't I have a fear of dogs and therefore I avoid them, but more of I have a fear of dogs and therefore I will not go to XYZ situation where I'm not going to go for a walk in the park because I know there may be a dog there and therefore I'm really afraid of that. Or I'm afraid of spiders and therefore I'm not going to leave my house because I'm worried that those spiders are going to come get me. That is above and beyond expectation for a fear that can be considered a normal fear of spiders or dogs or other situations like heights, but now is getting to the point where it's now affecting the day-to-day of the child. Panic disorder, kids will present with kind of the sudden onset of symptoms of intense fear, of worry, of crying. They're talking about, they're often their hands and feet. They have these feelings of numbness and tingling. Their heart is racing. They're feeling flushed, and these are recurrent and often situation specific, whether it's at school, etc. But again, and I hate to keep harping on this, but I think it's important. This isn't the child who really doesn't like to talk, do large presentations at school. Having some racing heart with that is perfectly normal. But now it's getting to the point where it's not just racing heart during these situations, but now we're having panic attacks, even just getting to the school or on the way home from school, etc. That's when that becomes a true, fully on disorder, anxiety disorder. And then there's just generalized anxiety. Again, just chronic excessive worry. These are the kids who, in order for you guys to plan a trip in 2 weeks, you have to spend every single day saying, this is what we're going to do. These are the things we're going to be doing on the trip. I have families where kids are planning, the plan is to go to the mall this weekend, and we have, okay, well, what store are we going to go to? And then if we don't go to that store, why are we not going to the store? We have to go along this path, driving to the school, driving to the mall, etc. And so again, this is now affecting in day to day, and you're spending more time talking about future things or worries than actually enjoying life. And that's now becoming a disorder as opposed to just normal anxieties that lots of us have. Anxiety and epilepsy as I mentioned earlier, is quite frequent, about a third of patients, which is understandable. They have a new diagnosis. They feel different from their friends and their siblings, and so there is understandable an increased rate of anxiety. And there are certain epilepsies, the temporal lobe, particularly in complex partial seizures, or what are often known as focal seizures, that can present with higher frequencies of epilepsy, of anxiety. And the idea there is the temporal lobe is kind of here on the sides of our head, and has parts like the amygdala, which is thought to be kind of simply as the fear center, and the hippocampus, which is part of our kind of memory and learning. And these, when there is seizures in these areas, there's often a higher emotion, and people can often, who have these focal seizures or temporal lobe seizures, often feel symptoms right before a seizure comes on, often a fear or other high emotions. And so it is not surprising that they often have a disorder of anxiety as well. There are certain medications. I put the generic name here, but I'll mention them, the brand name as well. But things like Keppra and levetiracetam, as I'm sure many of you have seen, this is a very frequent and common medication. And while it doesn't necessarily present with anxiety, it can definitely present with mood changes, things like irritability, things like anger, things like outbursts, or in our younger kiddos, things like temper tantrums and behavioral dysregulation, etc. Topiramate, or what's known as Topamax, and zonisamide or Zonegran are similar medications, and again can present with various changes in mood, and can are it's a necessary conversation with families when we're starting these medications to say, hey, let's watch the mood, make sure that this doesn't get worse. Vigabatrin is Sabril or Vigadrone are often used for more difficult to control epilepsies and seizures, and especially in infantile spasms, which is for our younger kiddos, and can also change mood and can change irritability and can cause things like anxiety. And perampanel, or what's called as Fycompa, is also another medication that's associated. Folks or children who are on multiple medications to help control their seizures also have a higher risk of anxiety. I think it's a bit tricky to assess at that time whether, again, is it the multiple medications, or is it the fact that they're probably on multiple medications because their seizures are hard to control, and it's really the increased seizures that are causing the anxiety, etc. But nonetheless, those who have multiple medications on board can often have high risks of anxiety. And then often some meds like gabapentin or benzodiazepines, which are benzodiazepines particularly are used in the lay population for anxiety. Once we use them very frequently for seizures, and so often there is some increased risk for anxiety symptoms after coming off of these medications. So that needs to be monitored as well. There's a question about children growing out of their mood or outburst stage when they start a new medication. It's hard to say. I often will push parents to wait for at least a week or two after starting a medication, because lots of side effects like sedation or sleepiness and sometimes mood can be present for the first week or two, but start to improve after a while. But if they're not improving after that period of time, and it's becoming a problem, leading to a disorder, it's actually impairing our day to day, then I start to think about switching the medications. Questions that I think are important for loved ones to ask or consider in terms of wondering about an anxiety disorder can include things like, does the child hate to be away from family? And again, most of our kiddos, especially the really young ones, prefer to be with family, but it's not just preference to be with family and siblings, but now avoidant of other situations, social situations. Our kids frequently asking about bad things possibly happening. I think it's hard when our news is often talking about bad things happening, and it's a constant conversation in kind of public. But at this point, this is now again becoming a point where the kid is constantly asking about things and constantly worrying about things, and now it's affecting their sleep and their eating and other things. Is this a child who's overly perfectionist? And what do I mean by that? I mean, this is a child who is so worried about making sure that they're doing their homework or whatever it is perfectly well, a puzzle, a game, practicing sports, etc. Now so worried about it that they're having a hard time actually doing the thing that they're so worried about doing well. Are they frequently comparing themselves to other kids their age who are doing similar activities? Are they avoidant of school? Do they have difficulty with strangers? Not just being shy and coy around strangers, but now being to the point where they're hiding behind you, not interacting with a stranger, etc. Having temper tantrums, crying whenever you are asking them to interact with someone else, whether it's a doctor or a teacher or someone else. Are they frequently asking about the future? Hey, what are we doing tomorrow? What are we doing next week? Well, what about after that? Where are we going to go in the mall? All those kind of things. And then obviously frequent symptoms of things like headaches and stomach aches, increased heart rate, lightheadedness, numbness, and tingling. And again, I don't want this to come off as, a kid who has headaches, it's got to be anxiety. But we should always be thinking in the back of our minds, especially for our seizure kiddos, often they have, let's say, an MRI of the brain because of their seizure workup. So it's unlikely to be something else that's causing the headaches. So let's fall back and wonder what else could be causing headaches, drinking, not sleeping well, etc. But then could this be anxiety related as well? Moving on to attention deficit hyperactivity disorder. This is another one that I think is important to think about, the level of inattention or difficulty with concentration. So again, this is a developmentally inappropriate level of inattention and hyperactivity and impulsivity. And I emphasize developmentally inappropriate because a 4-year-old or a 5-year-old who doesn't want to sit around for 2 hours doing a puzzle or homework or whatever it may be, it's probably not that inappropriate. But now you're asking a 10-year-old to sit down and do homework for an hour, and they really can't, and they keep getting distracted. That's probably a little bit developmentally inappropriate. A kiddo who's really young and jumping around and always on the go, again, maybe not inappropriate, but a 15-year-old should not be unable to sit still for 30 minutes for dinner, finish their dinner, and move on with their day. So again, age is an important aspect. And of course, obviously for our adults, that's not going to be something that we should be assessing, because the child should, or the adult should be able to do a lot of these things because of their developmental age. I think it's also important to, especially for ADHD, and I'll talk a little bit about anxiety and depression in the setting of intellectual disability and developmental delay for kiddos who have autism or other delays. Again, it's important to think about, well, they are 5 years old, but they're developmentally aged at around 1 or 2 years of age. Again, should I expect them to be able to sit around and do something quietly for 30 or 60 minutes? As with the other disorders, ADHD is now causing impairment or difficulties in schoolwork or social life or our emotional well-being. And interestingly enough, while in the general population, the ratio of girls to boys that have ADHD is about 1 to 2, it becomes closer 1 to 1 in children with epilepsy. Those of you who are older may have heard the term ADD. Often that comes up in my visits. That's actually now has been subsumed under the umbrella of ADHD, and we call it all ADHD as well. There is a strong heritability risk, meaning that it's often passed down from one family member to the next, similarly to anxiety and depression, but particularly with ADHD. And I think it's a bit difficult. I wrote here genes versus environment, or what we know as nature versus nurture. As I often talk to families about, if an adult, a father or a mother, also have ADHD and they live their world in an ADHD way fashion, children will pick up on that. Children will learn subconsciously or consciously to live their life as well in an ADHD-like manner. And I always talk to families, it'd be very hard. We don't have genes specifically that say, hey, if you have this gene, you're more likely to have ADHD. But we do know that it runs in families, and it'd be very hard to really truly know if it's genetic versus environment. We have to take 2 twins, take one twin and leave it in the family that has ADHD, and give the other twin to a family that doesn't have ADHD. And as you can imagine, that's not a very common thing that we do. There are other risk factors and things that are more likely to cause ADHD, things like intrauterine exposure to alcohol or smoking or opiates, issues at birth, things like bleeds or toxemia, meaning sepsis and things like that, eclampsia, this is maternal, or if the delivery was prolonged, and then adverse childhood experiences. So issues that happen during childhood, like trauma, like losing a house, like being homeless, losing a loved one, etc., that can also increase concerns for ADHD. Folks who have ADHD have high levels of what's called executive dysfunction. These are kind of those higher order skills that we as humans have developed, of thinking about organization, of prioritization. I have two assignments. One is due tomorrow and one is due next week. Well, which one should I do? I should probably do the one that's due today, or sorry, tomorrow, and not the one that's due next week. And then thinking about, how do I break down this complex problem that I have? How do I break it down into steps, and how do I do which one step to do first, and then which step to do next, etc. Keeping things in our what's called short-term memory when we're doing higher complex thinking. And then emotional dysregulation. Folks with ADHD often have kind of emotional outbursts, or have a difficulty controlling their emotions, often take criticisms or other things a little more severely, or with again, with outbursts, etc. And so again, these are symptoms that can come along with ADHD, are not part of the diagnosis of ADHD itself, but are frequently present in those who have ADHD, and so are important to think about as well. ADHD, I talk about with families that there's 18 symptoms. There's 9 symptoms on the left side of inattention. And these are things like kids who are careless with their work. They forget to do, they skip a problem because they want to go back, but then they forget to come back to it. Or they forget that this is a two-handed handout, and so they only do the front side and they don't do the other side, maybe because they got distracted. Difficulty sustaining attention. Yeah, they can do something for 10 minutes, but they can't do it for 30 minutes. And it's important to clarify that this isn't something that the child likes to do, right? A child, I often hear families, well, they can sit there for 30, 60 minutes watching their TV, but then they can't do their homework for 10 straight minutes. Clarifying to see how much is it they can't do it for 10 minutes because they don't want to, and they're just a willpower, or they truly can't because they get distracted, but they have hyper focus for things that they love, whether it's TV or reading a book or playing with a puzzle. They can hyper focus, but then for things they don't enjoy as much, they are unable to do it. They don't listen when they're spoken to. And again, not because they're trying to be oppositional, but because their mind is wandering elsewhere. They don't follow through on instructions. You say, go clean your room, and they go off, they start making their bed, and then, oh, well, what about this thing? And they get distracted. They have difficulty with their organization. They have difficulty sustaining their mental effort. And again, this is mental effort, not watching TV, but mental effort. I'm going to do a puzzle, or I'm going to do this complex problem set for school, etc. They lose things or misplace things. They're easily distracted, and then they're forgetful in their daily activities, brushing their teeth, getting dressed, showering, etc. And then there is the symptoms of hyperactivity and impulsivity. These are the kids who are fidgeting constantly, always on the move. They're leaving their seat, they're running around, they're climbing things, they're unable to play quietly. These are the kids who they're doing their puzzle, but you can hear them from the other room because they're always doing other things, or even watching TV. They're constantly doing other things. They're often on the go, and they're talking excessively to the point where now they're blurting out answers in class because they can't wait. They have the answer right away, or you're playing a game that requires waiting turns, and they're already moving on to the next step because they cannot wait their turn, and they're interrupting and they're intruding on others. They don't understand personal space. They're kind of next to you. They're intruding in line or other places. You need to have, in order to meet criteria for full-on ADHD, you need to have at least 6 symptoms in one category or the other. And then we sometimes, although it's not as important anymore, we sometimes will call a child who has 6 symptoms of inattention, we say ADHD, but predominantly inattentive. Or if they have symptoms just in the other category, ADHD, but predominantly hyperactive and impulsive, again, impairing in multiple areas at school or at home, etc. And then it has to be there for more than 6 months. This isn't a kiddo who unfortunately had a TBI and now is having ADHD symptoms, and we expect those to get better. This is now pervasive and persistent. And some of these symptoms have to be present there at some time prior to their 12th birthday. And this is actually a recent change. It used to be under 7, but now we say 12. And this is something that's important for kiddos where we start thinking about the higher IQ end of the spectrum, where kiddos are really, really smart. And yeah, they can kind of push through their first and second grade. And maybe there are some extra supports both at school or at home. But now we're getting into middle school, or now we're getting into high school. And now these symptoms are becoming unmanageable. And the supports that families have provided at home or teachers have provided at school are not enough to actually control these symptoms. And so it's actually becoming problematic. Again, as with anxiety being more present in temporal lobe epilepsies, we consider ADHD to be more of a frontal lobe. So kind of those high order thinking comes from our frontal part of our brain. And so those who have epilepsies in that part of the brain are more likely to have symptoms of ADHD. Folks who have childhood or even juvenile absence epilepsies, there are higher associations with drug-resistant epilepsies like Dravet or Lennox-Gastaut. And then an epilepsy that has gone by many different names, used to be benign Rolandic epilepsy, then became benign epilepsy with central temporal spikes, and now we've renamed it to self-limited epilepsy with central temporal spikes. And again, they often have subtle symptoms of ADHD that need to be assessed as well, because it's not the epilepsy that's causing the symptoms of inattention or hyperactivity, but really the ADHD itself. And as I mentioned earlier, it's important to consider when, as a provider, obviously for families to at least think about, is this inattention or difficulty concentrating? Is it coming from an anxiety? Am I avoiding public places? Is the child avoiding malls, the lunchroom because there's lots of kids and I don't know how I'm going to act with those other kids? You know what? I know it's my friend's birthday party this weekend, but I don't really feel like going. It's going to be a lot. And it's overwhelming. That sounds to me like a lot more like anxiety. But kids who are inattentive and distracted by, oh, well, there's a bird outside or there's a dog outside, or distracted by things on their table and they're constantly playing with their pen or their pencil or other things. And you look at their room, you look at their backpack, and it is a huge mess. Okay, that's probably more of an ADHD. And I think, again, we have to step back, and I tell families often, I have symptoms of ADHD when I'm watching TV. I'm often playing on my cell phone. I'm playing with my dog. I got this, that, the other going on. That's not the same thing. I can still function, i.e., get my work done and hang out with my friends and so on. But now it's the folks where they're unable to get their work done, unable to hang out with their friends, unable to do social interactions. That's where the ADHD is now becoming a significant issue. And between all three of these disorders, I think it's important to think about the connection between these disorders and the actual epilepsy. And so thinking about, especially for older children, particular adolescents and for adults, a new diagnosis of epilepsy takes some adjustment. Not only because it can often take a hit on their self-esteem, they feel different, they feel like they're now singled out in their classroom or amongst their friends or their siblings. They feel isolation because they may need to take medications at school, or they're worried about having a seizure at school, or they're worried about having a seizure at the sports game, etc. And so now they're worried, and so they're taking a step back. There's a new sense of identity that often can be a problem, where folks are taking on their identity of, I have epilepsy and this is what defines me, versus this is a part of me, but not really something that I'm going to let affect my day-to-day, etc. And that's a fine line between the two, and I think one that can be hard to distinguish. Often kids are, especially again teenagers, are what does this doctor know? What do you guys know? I don't want to take my medication. So they're non-adherent to their medications. They're worsening seizure. Now their grades are affected. Now there's a big a spiral downwards. We talked about it kind of adjusting to this the new diagnosis, and that can be difficult for our 16, 17, 18-year-olds, where they were about to drive and now they've got this new diagnosis and they can't drive until their seizures are under control, or they have activity restrictions. These are kids who are, they used to swim, or they used to do this, that, the other, and there are some restrictions that have been placed on them because they need to be watched. They have less autonomy because now somebody has to be always there when they want to bathe, or they want to go biking, or those kind of things. And so that can be really frustrating and upsetting to kids, causing things like depression and anxiety. In terms of treatment, I'm going to, again, be quite brief about this and not go into too much detail, but I think it's important to review what the most important parts of treatment are. And first line is always behavioral therapy. This can come in forms as cognitive behavioral therapy, and I'll review that in just a sec. Parent training behavioral management and parent-child interaction therapy. These are similar types of therapies. Parent-child interaction therapy are for our younger kiddos, symptoms, teaching parents on how to manage symptoms of anxiety or ADHD for our younger 4, 5, 6-year-olds. And then as we get older, it's often parent training, behavior management to teach the parent and maybe even the child how to manage symptoms of ADHD. What do I mean by manage symptoms? I mean, I give the example to families. When I come home, I put my wallet, my keys, and my cell phone all in the same spot so that when I'm leaving for the house the next time, I know exactly where to look for things. Creating or being organized, having frequent check-ins. Okay, you know what? It's dinner time. Let me check in on what homework I've got left to do. Did I put my homework back into my backpack when I'm leaving school? Did I put everything back into my backpack so I'm ready to go home, etc.? So managing symptoms is often the most important part of things like ADHD and anxiety, rather than starting medications. Cognitive behavioral therapy is the most common and most popular type of behavioral treatment for anxiety and depression. And you can see there on the right of the side of the slide, I talk about the connection between thoughts, which lead to feelings, which lead to behavior, which then leads to the thoughts. And now you've got a nice spiral again. And so thinking about your anxious kiddo, the teacher at school says, hey, we have a test next week. The first thought that the child with anxiety may have is, oh man, I have no time to study for this. It's 2 weeks. I'm not going to do well. I'm going to fail the test. And now we've got this spiral, and we have anxious feelings and worries. And then we're now behaving in a way that all we do are thinking about these. I'm not going to do well. And now I'm acting out. And now you got this spiral. And so what we work on in CBT, and by we, I mean psychologists, not me, is working on how do we get rid of those negative thoughts and have more positive thoughts okay, so I have a test next week. That's 14 days. All right, let me, or 7 days, I should say. Let me, there's 3 chapters I need to do. How do I get more myself organized? And this obviously, you can imagine, is more important for our older kids, a little bit trickier for our 6 and 7 and 8-year-olds. And so it's a bit of a mix between who can actually participate in these therapies. I'm going to jump to other considerations because I think it's also really important, especially in terms of managing outside things and trying to avoid medications as much as possible, which I hope is the message that you guys are hearing from me. Things like changes in our 504 IEP plans at school. So adjusting the kids' plans at school. So your ADHD kiddo should probably not be sitting in the back of the classroom where they can see 30 other kids and get distracted easily by those kids. Maybe should be sitting in the front and off to the side. Maybe the kiddos need extra time on tests or on homework assignments. Maybe they need, instead of just assuming that the kid is going to know what the assignment is, they need some printout or something, or some organizational thing that allows for them, for parents to check in on the child, etc. Sleep, exercise, and diet are things that, as a neurologist, I spend an inordinate amount of times on during my visits, because I think having a good, consistent sleep schedule, and consistent meaning appropriate number of hours for the child, and that changes as we get older, but it starts off where your 1 to 2-year-olds, somewhere around 12 years of age, and decreases steadily to your teenagers and adults to something about 7 hours of sleep. Consistent meaning on the weekends, we're not sleeping in until noon or even 10 o'clock. I try to be within 1 to 2 hour, maybe 2.5, 3 hour difference of what they're waking up on their weekdays, and not going to sleep obviously late. What are we doing the 30 or 60 minutes before we fall asleep? Are we on our TikToks? Are we on our Netflix, etc.? Are we running around doing things and trying to be more consistent about our nice, good sleep routines? Exercise is a wonderful thing. I'm not asking for marathons. I'm not asking people to join sports teams, but I am thinking about some moderate high intensity activities, getting that heart rate up, getting their sweat on, not just a leisurely walk in the outside with their dog, but something that actually gets some physical activity. And in the last couple of years, we've had more and more and more studies that come out that say exercise in and of itself can help things like anxiety and depression almost as equally as some of our medications. So let's do that. That has low side effect profile compared to some of our medications. Diet, not so much, I'm not saying you should be gluten-free or keto diet or all those kind of things, but thinking about, are we keeping a healthy diet? Are we eating 3 meals a day? We're not skipping meals. Are we trying to eat more more fruits and veggies and proteins and less of the things we all love to eat, the carbs, the pastas, the pizzas, the breads, etc. And so again, trying to have a well-rounded diet. And there, of course, for our more severe cases of ADHD, depression, etc., we have medications, whether they are for depression, anxiety, or SSRIs, or Zoloft, or Prozacs, or Lexapros, etc., or SNRIs, or Cymbaltas, the fenfluoxetines, etc. These are wonderful medications. I use them all the time, but again, as much as possible, I try not to start kiddos on these things. And unfortunately, one of the biggest problems with these medications is they take 4 to 6 weeks to start kicking in. So you're not going to have a response in the first couple of days or weeks, unlike some of our seizure meds or other types of meds where you can see a relatively fast response. For ADHD, we have lots of different medications. We have our non-stimulants, guanfacine or clonidine, things like Intenix or Intuniv are the other names for these, which are quote unquote blood pressure medications, but can help with some hyperactivity or impulsive symptoms. But they also can be helpful for some of the inattentive symptoms as well. They are not as successful in reducing the number of symptoms and not as successful on a population basis as our stimulants, your methylphenidates, your amphetamines, things like you guys may have heard of Ritalins, Adderalls, Vyvanse, Concerta, all those kind of things. We have so many ADHD medications. They come in so many different formulations. There are capsules that you open and put over food. There's liquids, there's chewables, there's medications that melt on your tongue. There's so many different formulations, and they are truly really helpful for ADHD symptoms. And so if other things are not helpful, I have a very strong conversation with families to say, this is what's really necessary for the child to be successful in their day-to-day. There are some SNRIs that can be helpful for ADHD, things like atomoxetine and viloxazine. This is your Strattera or your Qelbree. Qelbree being the newest medication. It was been used in Europe for depression for many years, and in the last, I think, 5 years or so, was approved by the FDA for pediatric and adult ADHD. There's some evidence that they work, obviously. They're still not as successful as our stimulants, but there is some good reasons to use this as opposed to our stimulants, which unfortunately are associated with things like appetite suppression, which can be quite harmful, especially for kiddos with epilepsy, as well as insomnia, which again is a huge problem if we're having epilepsy, etc. There's some role for over-the-counter supplements like magnesium. I use magnesium probably is one of the most common things that I recommend to families. It's helpful for so many things, and really the biggest side effect I have from it is maybe some sedation, some sleepiness, and maybe some looser stools. And honestly, magnesium citrate particularly is something we use for constipation, but it's really good for anxiety, for ADHD, for helping to fall asleep, for headaches, so many things. And it's such a nice, easy supplement that it has low harm and high reward. That it's an easy thing to start before we start some of these other medications. And this little animation that I just did is just, again, to emphasize how really important it is to think about behavioral therapy and other considerations like sleep and IEPs and so on before we jump to medications. The question in the chat in terms of when I start kiddos with SSRIs and SNRIs, this really depends on the child. I have started kiddos as young as 4 or 5 because of severe anxiety. Again, I try as much as possible to avoid it, but depending on the child, and part of the problem is depending on the developmental stage and maturity level, if this is a 5 or 4-year-old who's got severe autism and severe intellectual disability, but has a lot of anxiety and doesn't want to be out in public and this and that, and can't participate in the therapies, their ABAs, their PTs, their OTs, and again, really can't participate in behavioral therapy to some degree. They're not going to sit down and chit chat with the provider about, here are my thoughts and my worries. Then yeah, I'm much more prone to start a medication, but again, I try to avoid it as much as possible. The question about magnesium glycinate or citrate, really this glycinate has the least side effects, but probably the least effective, as most things in life. Anything that is effective is more likely to have side effects. Citrate is most likely to cause diarrhea or at least looser stools. But again, every kid's a bit different, and I have a conversation about maybe trying something else if one is causing issues, etc. Brief kind of interlude in terms of therapy, as I kind of mentioned earlier, the child needs to be an active participant in the therapy. This can't, we've got these moody teenagers who have anxiety or depression or ADHD, and they are not open and comfortable with the therapist. And so, as much as I want you to try that, at some point, if the child isn't really opening up about things and instead just talking about, hey, I really like pizza and I like pepperoni on my pizza, that's not what we're there to discuss. And so is maybe not as helpful for that child, unfortunately. At the same time, I do think it's important to emphasize how difficult it is to find a therapist, to find therapy, one from insurance standpoint, but two, just from a waitlist standpoint. As I'm sure many of you have read or seen, there's a huge dearth of therapy and mental health problems in this country, and so it's something that's really hard to find a therapist. So when you do, I emphasize to the families, even if the child maybe didn't like them on the first visit, maybe please give it another 3, 4, 5 visits before we give up. And then it's really important that the therapist talks about, gives exercises, things like journaling, other things to talk about, and that the child practices them. The families are participating in some of that practice, or at least reminding the child to practice those things, because as with everything in life, practice makes perfect. How do we find the therapist? Again, like I said, tricky. First step, definitely have a conversation with your insurance company. They often, either online or when you call, can give you a list of therapists that they cover. Psychologytoday.com is a great resource. You can put in your zip code or your city. You can narrow it down by your insurance. You can narrow it down by the type of therapy, and then you can narrow it down by the child's age, as well as even the gender of the therapist. Your teenage boys may not want to talk to a female, or vice versa, etc. And so maybe your 10-year-old is not so interested in talking to an older therapist and wants a younger therapist, or vice versa. So again, these are conversations to be had. And then often there is therapists that come along with the neurologist. And so having a conversation with them, especially if you're at a large center like CHOP, we often have therapists that are part of our epilepsy teams. And so you can get that referral, at least as a beginning step in managing some of these disorders. Brief word on medications. There was previously a fear of the use of stimulants like Ritalin and methylphenidate and amphetamines in those who have epilepsy. They are perfectly safe. There's thousands of kids who are on both of these medications and are doing perfectly fine. Obviously, there's always a case here and there where that can become a concern, but in the grand scheme of things, it's a worthwhile thing to try before just assuming it's unsafe. And again, it's really important to think about that untreated or undertreated, poorly treated ADHD that is not controlled comes with risks, comes with self-esteem problems, comes with worsening anxiety, comes with accidents, more frequent visits to the emergency room for broken bones or hurt parts of our body, things like substance use, etc. So again, really important to have that conversation about the costs and benefits. Some seizure medications are helpful for mood, things like lamotrigine or Depakote. Again, they all come with their side effects, but thinking about can we use a seizure medication like that to help both manage the seizures and our mood issues as well. And then again, mood medications, especially SSRI, Zoloft, there's some connection between the use of those and a reduced seizure threshold. In general, in the grand scheme of things, for most of our kiddos, this is not true, and they can do both safely. But on the general, if you look at the general population, kids who are on these medications have a higher seizure frequency. But again, this is not true for the individual. Things to consider at home while you're waiting for that therapist, because it's been, you're on a wait list for 6 months, is try some apps at home. We've got apps on the left side here for our younger kids, including ones that are made by our federal government, like Breathe to Relax, and then apps that you might have seen on the right side for our older kids. And even programs like Healthy Minds program, for example, has wonderful, quick 5-10 minute exercises for your busy bodies, where they're able to do, maybe try them right before going to sleep, etc. Again, important to to continue to do breathing and relaxation techniques. As I talk about, let's say we're using this for anxiety or panic attacks, it's really not helpful to just do it when the panic attack is going, because now the car is driving at 60 miles per hour. If we can do this when the child is starting to ramp up and the temper tantrum is starting, it's a lot better when it's just starting, rather than when it's already speeding down the highway. And again, thinking about if we practice, it's a lot easier for me to play tennis play a match in tennis once I practice for 10 years, rather than just show up to the match and just expect me to be good. Last but not least, there's some websites you can Google. CHOP, either for our Center for Management of ADHD. There's lots of websites and lots of helpful techniques for families. Integrative Health has lots of resources in terms of breathing techniques, relaxation techniques, meditation, etc. And then some other websites that can be helpful as well. In conclusion, I'm rushing through the end here. Mental health problems do and can occur in children with epilepsy. They don't happen with everyone. So I don't want the takeaway from this is all of you to take your child and tell the neurologist, I think my child has anxiety, ADHD, etc. But it happens frequently enough that definitely should be a conversation with your neurologist if there is concerns. And then treatment includes things like behavioral strategies. Medications should focus on behavioral and management at school and at home, and if necessary, can include things like medications as well. And I'm going to stop here. Hopefully I didn't go too much over time. Oh,
No,
guess
you're
I did, but
fine.
sorry.
That's okay. Thank you so much, Dr. Alperin. That was fantastic. You had so much information in that amount of time. It was great.
Thank you.
I have one question that they asked is, do you have any tips, a child that has no problem going to sleep but staying asleep?
Yes. It's tricky. Again, as much as possible, behavioral, right? So I think people have this idea that waking up in the middle of the night is abnormal. Obviously, if it's related to snoring or breathing problems, that needs to be assessed. But if it's a matter of I wake up in the middle of the night and it's hard for me to fall back asleep, the waking up itself is not abnormal. We all wake up in the middle of the night. We just don't remember because we fall right back asleep and we're able to self-soothe. Kiddos who have trouble with falling back asleep, one is thinking about behavioral ways. So relaxation breathing techniques. It is not take out your cell phone and try to play some games. It's not go and eat something, etc. Stay in your room, stay in your bed. If you haven't fallen asleep after 15, 20 minutes, leave your bed, stay in your room, read something really, really boring, and then go back to bed. Staying in bed for more than 15, 20 minutes and looking up at the ceiling and counting sheep and all that stuff doesn't work. Long-acting medications like melatonin can help sometimes. There are other medications that can be helpful for sleep, and sometimes they're necessary. But again, as much as possible, working on behavioral changes, particularly one that I think is most common for our adolescents is they're busy doing other things in bed on the weekends or even just in the late evenings, like playing on their cell phones, TikToking away, whatever it may be. As much as possible, our bed should be for one of three things: falling asleep, being asleep, or waking up. It should not be for anything else. And again, it's a hard thing for teenagers to take a hold of, but as much as possible, the head hits that pillow, we should be going off to bed.
Good advice. Thank you. Thank you so much. We appreciate it. And you are recorded, so I know people will be watching this over and over again. I certainly will.
Thank you.
So, Rena, shall we go maybe a 3-minute break? Everybody just grab something to drink and be back in 3 minutes. Don't go away. And then we'll have Dr. McInerney speak. And thank you once again, Dr. Alperin.
No worries.
Oh, so fast, trying to get it. Okay, welcome back, everybody. Now we'll start the second part of the program. Maura McInerney, Esquire, lawyer and legal director at the Educational Law Center. Ms. McInerney serves as a legal director at the Educational Law Center. She has been a litigator in the private and public sectors for over 35 years. Since arriving at the Educational Law Center in 2007, she has litigated precedent-setting state and federal cases, including impact litigation on behalf of children in foster care, students experiencing homelessness, and students with disabilities. She also engages in litigation and policy work for the national and state level focused on advancing the rights of students who are most underserved, particularly students in foster care. She represented EEC as a founder member of the Legal Center for Foster Care and Educational prior to coming to EEC. She also co-counseled numerous cases, including trials and appeals in the federal, state, and administrative level. As an assistant attorney general for the state of Maryland, she handled dozens of administrative hearings and appeals. She also serves as a law clerk for the U.S. Court of Appeals for the D.C. Circuit. Ms. McInerney is currently lead co-counsel in a class action lawsuit challenging the mistreatment and failure to educate youth at Glen Mills School, formerly the nation's oldest reformatory school, until it was shut down by the state in 2019. She was also lead counsel in Pennsylvania's Act school funding lawsuit, which resulted in Pennsylvania's school funding system being declared unconstitutional. So, Maura, the floor is all yours.
Thanks so much. And I apologize for that very lengthy introduction. And thanks to Rena for sharing the PowerPoint. Thank you. I really appreciate the opportunity to be here tonight. The Education Law Center is a statewide legal advocacy organization. We have offices in Philadelphia as well as Pittsburgh. And we essentially are focused on ensuring a quality education for all students statewide. We accomplish that mission by focusing on students who are most at risk educationally, most marginalized by our education system, including children living in poverty, children with disabilities, English learners, children who are in the foster care, juvenile justice system experiencing homelessness, and students who identify as LGBTQ. And we work in 3 strategic areas. We do this through impact litigation, such as the class action lawsuits that were mentioned against Glen Mills. We also engage in individual representation. We have a helpline where we essentially handle about 1,600 intakes that come to us every year. And in addition, we engage in policy reform at the local, state, and federal level. And most currently, Section 504 is in the process of being revised. And that's an area where we've submitted comments, and I invite others to share your thoughts with me and with others about how we could strengthen Section 504 to be an effective tool to ensure an end to discrimination based on disability. So tonight, I'm trying to see how to advance the slides. My apologies. Okay. So just to underscore, the Education Law Center does work in 3 priority areas. Equal access to quality schools, which is the focus of tonight's presentation. We also try to ensure adequate and equitable school funding, such as the school funding case that we recently litigated, where education was declared a fundamental right in Pennsylvania, and the court held that our system of funding schools is both inequitable and inadequate, and we're in the course now where we're trying to reform that. We also work on dismantling the school to prison pipeline to ensure that students are not excluded from school and that they're able to be in school and have access to quality education. That includes children who may be in the juvenile justice system, in detention centers, etc. So today we're going to talk about an overview of the laws that protect against disability discrimination, the affirmative duties of school districts, what parents can ask and need to do as part of that 504 process, how to develop an effective 504 plan, how to challenge discrimination, how to handle disputes, and as well as advocacy tips and some resources that I hope will be helpful. But more than anything, I'm hoping that we can have chance for questions and answers that you might have. Okay. I don't know why it's frozen. My apologies. Okay. So the legal landscape includes several federal and laws that are particularly important. Everyone on this call may be familiar with the Individuals with Disabilities Education Act, the IDEA. Essentially, that ensures that children who need it receive specially designed instruction. Those are children with qualifying disabilities who need access to education by ensuring that they have teaching methodologies, changes, specially designed instruction that enables them to secure equal access to learning and that they can make progress and receive a meaningful benefit in school. It also includes very specific prohibitions and protections in the school discipline context. We are also going to talk tonight about the Americans with Disabilities Act, Title II of federal law, which ensures that children are not discriminated against based on their disability. And we're also going to talk about the ADA and its interaction with Section 504, which I am hoping that everyone on this call is familiar with. And that ensures that children who have qualifying disabilities have access to learning, modifications to curriculum if needed, have access to services, accommodations in schools, so that they have equal access to learning on an equal playing field. Chapter 15 of our state law is essentially the implementation of Section 504, so that applies to all children who have qualifying disabilities. Under the IDEA of the state law, we have Chapter 14, which again is a more specific implementation of the IDEA. I wanted to just specify here and pause that the IDEA and Section 504 are different laws, but that section of 504, an accommodations plan, is not like, sort of a concession prize that you receive if you don't qualify for the IDEA. There are in fact separate laws with separate provisions, and it's children who need specially designed instruction must have an IEP that delineates what their rights are, what program they will receive, what aids and services, related services they need and are entitled to. Section 504 looks at every qualifying disability that a child might have. Dr. Alperin was talking about 1/3 of children who have epilepsy potentially suffering from anxiety. That's a recognized qualifying disability under the ADA. So you would want to ensure that your 504 plan is addressing not just epilepsy, but any other disability that's an impairment to learning. And we'll talk about what that means. The ADA was actually modeled after the Rehabilitation Act of 1973. It's a subsequent law. So when I talk about these laws, it's important to understand that there are a lot of parallels. They use a lot of the same language. So I'm going to talk in general as a legal overview of what these laws provide for students. So who is eligible for protection? It's a student who has physical or mental impairment that substantially limits one or major life activity. That could be walking, that could be breathing, it could be learning. So all of those are major life activities. The student must have a record of such an impairment, a past history of impairment, a past diagnosis, although importantly, a medical diagnosis in and of itself is not sufficient to establish your right to accommodations. You have to go through an evaluation process. And importantly, it's also someone who is regarded as having an impairment, even if that impairment does not limit a person's activities, but if it's believed to do so, if it's a perception of having a disability, you are also protected against discrimination. And an impairment should be measured by the time the condition is most severe. when we talk about epilepsy and some other conditions, they may be episodic. What we focus on in terms of ensuring that you have a 504 plan that provides accommodations is focusing on the time period in which that might be most severe. So if it's intermittent, if it's episodic impairment, the ADA and 504 looks at your child's symptoms when they're most severe because you want to ensure that there's no discrimination in that context. So here are some examples of qualifying disabilities. In 2008, the Americans with Disabilities Act was actually revised significantly and amended to broaden the definition of physical or mental impairments. So these are some examples. It's not an exhaustive list, but you see ADHD, which may entitle your child to an IEP and require specially designed instruction, or it may be that your child needs a 504 plan. Asthma is a very common qualifying disability, diabetes, but we also see depression, alcoholism, dyslexia. All of those would be impairments that interfere with major life activities and would be recognized as such. Drug addiction is not that, but alcoholism is recognized. So what is the prohibition? And this is in general, no qualified individual with a disability shall, by reason of such disability, be excluded from participation in or denied the benefits of the services, programs, or activities of a public entity or be subject to discrimination. So this ensures that a child in school has not only access to the classroom and is in a regular education setting and is not isolated, but in addition, in terms of access to extracurriculars, to sports, to any service, any benefit, a field trip, to ensure that that child is not discriminated against based on their disability, but rather has equal access to the services, programs, activities. It includes testing. It includes also your time beyond when you are in school, obviously. It applies when you are in college as well. Students have 504 plans, and those protections continue. So public school entities cannot discriminate directly or through contractors. So there may be a service or a program that's provided through a contractor with your school. That contractor also cannot discriminate and must ensure that accommodations are available to the student. Public school entities cannot discriminate against students based on their disability in any way. This includes private schools that are receiving federal dollars. So my focus tonight is going to be primarily on public schools, but it's important to recognize that this protection also applies in other contexts. So a school district may not establish requirements for its programs or activities that would result in discrimination. So you'll see there may be policies with regard to truancy or regard to other different issues, and all of those must be amended to ensure there can't be discrimination based on disability. School district must provide reasonable accommodations for students, and public entities must make reasonable accommodations of its policies, practices, and procedures. So we need to ensure that this is done both at a systemic level with regard to policies or procedures, and also that a child receives individual accommodations based on their needs. So here's some examples of discrimination in the school context: a constructive exclusion from school or the classroom or a school activity. If a child is sent home because of an episode that needs a response from the nurse, that's not a reason to be sent home. That's a constructive exclusion. A student who is unable to access the curriculum or extracurriculars or sports. If a child is prohibited from playing sports due to a risk of an episode. A benefit administered in a way that it, quote, effectively denies meaningful access. So if there's a science experiment and there's a concern that a child with a qualifying disability shouldn't be able to participate, all of those are examples. Courts consider the circumstances, so the degree of hardship on the school, the reasonableness of the modification in light of its costs, and the availability of reasonable substitute activities. Importantly, I want to underscore that it's the duty of the school to provide the modifications, to pay for the modifications or services, And it's a matter of importance to ensure that a child is able to receive equal access to education. Retaliation is prohibited. Schools can't retaliate because a parent or a student has disputes whether or not they're receiving what they need under an IEP or under Section 504 accommodations plan or service plan, because they filed a grievance, because they are challenging it in some way. And schools can't coerce, intimidate, threaten, or interfere with a student in the exercise of rights. And the elements of retaliation claim are that the parent or student engaged in statutorily protected activity. For example, you asked for the child's records because you explained that you're concerned that you're not receiving all the records, and also that the student or parent suffered an adverse action causally related to the protected activity, meaning that it happened temporarily within the time frame. You filed a dispute and suddenly your child was not able to participate in some activity, or the parent is excluded from school. Not every unkind act, of course, is adverse, but rather the inquiry is whether a reasonable person in that position would view the action as adverse. So Section 504 is a federal statute that prohibits disability discrimination, the provision of programs. It applies to public schools. It applies to some private schools, depending on whether they're recipients of federal funding. It requires students to receive equal access to learning and a free, appropriate public education. We often hear that terminology with regard to special education under the IDEA. It applies with equal force to children with qualifying disabilities who need accommodations, services, interventions in school. Section 504 statute and regulations are less prescriptive than the IDEA. And I'll go over sort of the process in terms of an evaluation, what the timelines are. It's much more prescriptive in the IDEA process, particularly with regard to ensuring protections in the school discipline context. However, a child is still entitled to accommodations, services, modifications to ensure that equal access to learning. So what are the duties of schools? So schools must identify students who need accommodations. An accommodations plan under 504 can happen by virtue of a teacher saying, oh, I think this child may need accommodations under Section 504, or by virtue of a parent raising the issue, maybe something that the school doesn't know about. So the parent may ask for an evaluation. In that context, under Chapter 15, if you ask for an evaluation, the school district has 25 school days to respond to that request for an evaluation. Unfortunately, under federal law as well as state law under Chapter 15, there is no timeline for completing that evaluation. It must be within a reasonable time, and then it must be implemented within a reasonable time. That is not defined under the law. In the IDEA context, a reasonable time has been seen as 10 days as being reasonable, but that is not something that is clearly delineated under Section 504. But it's 25 days to respond as to whether they will conduct an evaluation. If a school district says they will not conduct an evaluation, then the parent can challenge that. And there are many ways to do that, which I'll talk about. So it may be that the IEP team determines that special education services are not necessary, but accommodations are needed to provide a means to the education that is equitable to non-disabled peers. So it does occur in that context as well, that an IEP team decides after having looked at an evaluation that a 504 plan is indicated. Teacher may recommend it, but very importantly, a parent may request at any time, should be in writing, that a student be evaluated for Section 504 services, and that can happen at any time. Under the IDEA Chapter 14, if a parent asks for it verbally, then within 10 days, that school district must provide a permission to evaluate form. That is not as prescriptive in Section 504. However, if you ask for it verbally, they should give it to you within a reasonable time. So the evaluation process. Importantly, evaluations are conducted by professionals familiar with the conditions at issue. Every school district does it differently with regard to their evaluation process. So one of the most important questions to ask is, what is the evaluation process? Who is the team? Who do I speak to? It may be through the school nurse. It may be through the special education director. It may be through a guidance counselor. But we have to ensure that the evaluations are conducted by professionals who are familiar with the conditions at issue. And of course, that includes the parent, who's going to provide the most important information about the child. The evaluation should include information from various sources, parents, medical personnel, school psychologists, teachers, anyone who interacts with the student on a regular basis. By providing this team to do the evaluation and to engage in the discussion, you ensure that you are providing appropriate and effective accommodations, not only in the classroom, but also on the playground, also during extracurriculars, ensuring that the child, that there may be issues that would be identified in other contexts that we've accounted for. If a student is determined to be eligible for services, then it must be a written service agreement that must be developed to meet the needs of the student. The parent must sign off on any evaluation under Section 504, and a parent must sign off with regard to Section 504 accommodations occurring. And that's the juncture where you can dispute whether or not you believe these accommodations or services being offered would be effective. There are many ways to dispute these issues. One way is to obviously talk to the school district or personnel and say, I disagree. I think my child really does need this accommodation, or I think my child really does need the Section 504 plan. If they don't agree, you can go to mediation. You can file an administrative complaint with the Bureau of Special Education at the Department of Education in Pennsylvania at the state level. That has specific timelines by which they have to respond. You can file a federal complaint to the Office of Civil Rights. That does not have a timeline for them to respond. And in some cases, it may take a long time. There's also a PHRA, the Pennsylvania Human Resources Commission, who you can also file a complaint there. You can also file for due process with the Office of Dispute Resolution. And in that case, you can have a due process hearing. You can also go to federal court to challenge disability discrimination under Section 504 and the Americans with Disabilities Act. So developing effective Section 504 plan. The service agreement must outline the accommodations that have been agreed to by both the school and the parents. The more specific it is, the better. Identifying personnel who will be responsible for the Section 504 plan. Identifying who will administer a medication, what the timeline to administer the medication. The LEA requires parental consent prior to providing any services. So you may have a Section 504 plan that's been presented to you. If you have not signed off on it, they do not need to comply with what is in the plan. All personnel working with the student must get a copy of the plan, be aware of the provisions in the service agreement so that it can be effectively implemented across the board. That includes substitute teachers, making sure that they know about this. The plan should be reviewed annually to ensure that it remains current, that it's most effective, should be done on an annual basis, or if there's a change in the child's needs or the child's behavior, then that plan should be changed and revised at that juncture. There's parental notification is required if there is any change to the service agreement or if the student's eligibility for services or accommodations changes. A school district cannot make a unilateral decision that a child is no longer eligible. This is a determination that must be made that with the parent's input, and the parent has to receive a procedural safeguard notice. Just as you have under the IDEA, you have the same protection under Section 504. That procedural safeguards notice apprises you of your right to sign off on it, your right to dispute it. It explains and delineates your ability to challenge it. and it provides timelines for when the Section 504 plan will be complied with and be fully implemented. So those are important procedural safeguards that is the duty of the school district to ensure are in place. So you also must understand that you have a right to receive records, to receive any progress reports, if there are any issues with regard to implementation of the 504 plan. Under the Family Education Rights and Privacy Act, you at any juncture can get access to your child's records, and you determine who they are shared with. For example, if a school district has a program with a contractor and you don't want the contractor to receive significant mental health records of your child, you can say, I don't want that information disclosed. I only agree to share that information with these particular people. So that is all up to the parent or guardian or other person acting in the place of a parent to determine. If there's any substantial change in placement, that requires a new evaluation. If the school district determines that this classroom they don't think is appropriate for your child, or that this program the child shouldn't be able to participate in for some reason, that cannot be done unilaterally, but rather it requires an evaluation if they're going to make a substantial change. And again, parents must sign off. So this is a legal document. A 504 plan is equivalent to a federal contract between a public school and the student and his or her parents. So it can be enforced in a court of law. It can be enforced administratively, but importantly, it must be complied with. 504 plans must be fully implemented by staff at all times. Particular issue because it's about health, it's about safety, and we must ensure that everyone knows about it. The team must be proactive, meet when the student is struggling or when there's a change in circumstances. I think sometimes everyone gets used to sort of annual reviews of something, but in fact, we want to make sure that if there is a change in circumstances, if there's a new issue for the child, or there's been a psychiatric hospitalization, grades are dropping, or there's some new anxiety, that we're considering whether the 504 plan should be amended and additional or updated evaluations are necessary. So that's important to do. So sorry, I'm having trouble navigating. Okay. Importantly, we often talk about manifestation determination reviews in the special education context. Just want to highlight that a child cannot be disciplined because of their disability. There can't be a change in placement, meaning that a child is out of school for over 10 days. There can't be an exclusion like that. We must ensure that children are not discriminated against based on their disability. So a meeting must be held before discipline is imposed to make sure that whatever they're being disciplined for isn't actually related to their disability, the result of a failure to follow a Section 504 plan or an IEP, and that the school is actually following the Section 504 plan or IEP. So children under Section 504 are entitled to a free, appropriate public education at all times. They're not receiving that, then that should be challenged. So students who have a 504 plan or IEP are entitled to a manifestation determination review prior to any change in placement. And we don't often think of that, but it does apply. Or if you believe they're being discriminated against based on their disability, that's a challenge you should bring up. So students who do not yet have a 504 plan or an IEP are also entitled to manifestation determination review in the school discipline contest because it's suspected that they have a disability interfering with their learning. So if the school has knowledge of the disability before the behavior, then that right applies. So knowledge includes a parent expressing the right or concern in writing that the student needs accommodations, parent requests an evaluation for the student, or teachers or school personnel expressed a specific concern about a disability. So questions to ask: who in the school is responsible for conducting an evaluation for eligibility under Section 504? Who are the members of the evaluation team for the Chapter 15 or Section 504 requests. It sometimes is referred to as a service agreement as well. What is the time frame for evaluating and reevaluating students for Chapter 15, Section 504? Who is responsible for overseeing the Section 504 compliance at the school? If you have issues regarding compliance, who should you go to? What policies does the school have in place to ensure non-discrimination against students with disabilities? Is not happening. So we want to make sure that we know sort of what the context is, what the terrain is. But it's important to emphasize that if a child is currently at risk, if there's a safety or health concerns, all those should be highlighted and underscored. And it's the duty of the school district to ensure that that child is safe at all times, because it's really a matter of safety. So some things to look at in a Section 504 plan are environmental strategies. Think of the context in the classroom. Does the child need seating away from distractions, near the teacher, away from the door, quiet place to complete work or tests? Adjust the class schedule. It's important to approach the Section 504 not from the narrow provision of my child has epilepsy and needs access to medications. My daughter has type 1 diabetes. She needed accommodations in school, but we also want to ensure that we're looking at the child in a holistic way in an all context. And with regard to any disability, a child doesn't have sometimes one disability, but may have more than one. And we want to make sure that we're addressing all of them. So looking at whether the class schedule needs to be addressed, or whether the child needs regular breaks to allow for movement, or are there other adjustments that need to be made for non-academic times. Evaluation methods. Does testing need to change? Does the format or delivery need to change? Should tests be chunked into smaller questions? Do we need stop the clock or getting breaks or breaks between sections? Do they need extra time on tests? Do they do better with multiple choice tests, etc.? Assistance during test preparation. Are there certain things that would assist the child in order to be prepared for testing to ensure that they have equal access? Communication accommodations. This includes setting up a school and homeschool communication systems, that there's a notebook between the teacher and the staff to record information, that there are regular emails and phone calls with the parents. That kind of communication plan should also be in the Section 504 agreement. Organizational strategies. Do we need to modify classroom homework assignments, shorten the assignments, extend time to complete the assignments? Do you need to break down long-term assignments with separate due dates? All of these things, clear, simple directions. Does it help your child to repeat directions or to have post-homework assignments, verbal instructions? Are they a visual learner? All of those things should be assessed and evaluated. Do we need to modify teaching methods in any way? Verbal cues, hands-on activities, highlighting important parts of a task, reducing demands on memory skills, or teaching memory skills to your child? Does the child benefit from multisensory techniques, guided notes, outlines, small group discussions, peer tutors, cross-age tutors? All of those things should be considered. And I know it's a pretty long list, but it is important to really break it down and to try to look at all of these different areas and strategies. Behavioral strategies. Is there a positive behavior support plan that needs to be put into place? Any kind of system of prompts, feedback, redirection, rules, consequences for behavior, reinforcing self-monitoring, self-recording of behaviors. Are there things that work at home for your child that should also be working for them at school? So all of those things are areas to think about. I just wanted to go back for a minute, because it is important also that I don't know, I'm not seeing it here, but there are also some model plans. There's certainly, there is one, it should be in here, hold on. So a model Section 504 plan for a student with epilepsy, there's a very good one that is actually on the Epilepsy Foundation website. Provision of epilepsy care, staff members receiving general training, critically important for epilepsy and other conditions regarding epilepsy, first aid for the person who is having a seizure. All staff members need to, at the school, who are serving the student shall receive general training on the protocol to be followed. It's critically important that not only are you looking at what does the child need, but what does the school district need to do to ensure that your child is receiving accommodations. It often includes training of school personnel and staff and awareness of staff to recognize the signs of a seizure. So a student's level of self-care, that will evolve over time. So in elementary school, they may need more intervention than middle school, or it may change depending on the child. Where are supplies and equipment located? Everyone should have access to that information. Changes with regard to exercise, physical activity, rest period, diet, classwork and tests, field trips, extracurricular activities. All of those should be in the 504 plan. I've looked at a lot of 504 plans as part of my work, and often I see that they're very lackluster, that they're not as directive as they really need to be to ensure that they are effective. So using very directive language, being as specific as possible about who will be doing the work and how will it be done and at what intervals and what time frame, ensuring that training is done across the board for all staff. All of those are critically important to do. So Education Law Center has a number of resources that we hope will be helpful about accommodating health needs in school 504 plans. We also have partnered in a medical legal partnership with some medical schools to develop some model 504 plans for different issues. I also wanted to highlight that your child may be entitled to compensatory education for the failure to provide a free, appropriate public education. We sometimes talk about compensatory education services. They are quote unquote make-up services for a time period where you were deprived of a free, appropriate public education. And I'll use as an example, COVID compensatory services. So during COVID, many children, both with IEPs as well as children with Section 504 plans, were actually not able to engage meaningfully in school. Virtual learning didn't work for them. Accommodations that they should have received were not available to them during that time period. Children with 504 plans are entitled to quote unquote compensatory education services for every hour of every day that they failed to receive a free, appropriate public education. We recently filed an administrative complaint in the School District of Philadelphia that impacted thousands of children, over 20,000 children in the School District of Philadelphia. And that administrative complaint to the Bureau of Special Education at the Department of Ed concluded that every child who is eligible for an IEP or under Section 504 qualifying disabilities were all entitled to an evaluation to determine whether they should receive compensatory education services. That comes in the form of money for tutoring, things that access to educational services that a child was deprived of during that time. So compensatory education services are an important right for children with disabilities, and we have a fact sheet on that. We also have students' rights in partial hospitalization day treatment programs, the right to compensatory damages for disability discrimination under last year's Supreme Court decision that said, yes, children that all people are entitled to money damages for disability discrimination. That's something that you are eligible for under 504 in the ADA. And we also have self-advocacy tools like requests for a determination of eligibility under Section 504. They are fillable forms, they're easy to use so that parents can easily request eligibility for Section 504 and say, I think my child needs to be evaluated. When you request that, do it in every area of suspected disability to make sure that the evaluation is full and comprehensive. So every year we do a back to school guide. This is one for 2023. These are some of the titles of the fact sheets that are available on our website. And I just wanted to say too that we have something on, I apologize for my dog, that we have something on bullying and harassment as well. Unfortunately, we've seen an increase in bullying and harassment based on disability, based on race, etc. And so we have a toolkit on that, the rights of students, the obligations of school districts to ensure that your child is free from harassment and bullying based on disability. We also have several fact sheets for students with disabilities that walks through an IEP process. It walks through timelines. We have a flow chart, etc. But all of those resources are available on our website. And I just wanted to leave enough time to answer questions that folks might have. And this is also my contact information.
Okay, we're ready for any questions. And thank you, Maura. That was so informative. It's great information. A lot of you are school nurses that are on our program tonight listening. Like Maura said, there's bullying, and we do programs in the school. We can train not only the teachers, because the nurses can't be everywhere at all times. So we train the teachers to know what to do with epilepsy and things, but we do a program for the students, for the children, explaining what the disability is. And then we show them how to do first aid. And they're like little sponges. We do it from preschool up to high school. And we do it age appropriate. We use puppets, or we use storybooks, or we use student hands-on. But the more they know, the less likely they are to bully. And that's why we try to get, if you, any of the teachers or anyone out there wants a program, we're more than happy to come to the school and do it for the teachers and the children. Let's see, school nurses use IHPs often. How do they fit in with all of this?
Should I start with the questions that are in the chat?
Yes, that's the one that I have first.
Oh, okay. I had one that was, how about a deaf child who also has ADHD and epilepsy?
Oh, okay, yes.
So that child should have an IEP that would address all of those issues in that document to make sure that they have the accommodations that they need for ADHD as well as for epilepsy. Because you have a primary disability and you also have secondary disability categories. So for example, it may be that you qualify for specially designed instruction. Obviously, a deaf child would qualify for that. And then ADHD would also need accommodations under other health impairment, as would epilepsy. So that would be your secondary. And you want to make sure that the accommodations, the services that a child needs are comprehensive and in one place and can be addressed in that document.
Good. The next one is, my son is in public school and it's hard to get the school to write anything in his 604, even if his doctors are writing notes, and are giving me a ton of issues with him missing school for him having seizures as well as doctor's appointments, even with provided notes. Is there anything that they can do?
Yes, certainly we like to start with addressing it with the school district and explaining that this is very concerning because there's a concern here that they're really discriminating against the child based on the disability. The 504 plan, if it is not detailed enough, if they're not putting things in writing, it needs to be in writing to ensure that there's equal access to learning. So that would need to be addressed first. I would recommend that the doctor come and participate if possible, or someone from his or her office participate in a meeting. I would first recommend that they have that meeting so that the doctor can explain exactly what the child needs. In addition, on the truancy issue under Act 138, our state law, if you have a note that explains why the child was absent from school, they need to accept that. We've engaged in a lot of instances where we've actually had a child's records changed under FERPA because the child should have been excused. It should have been an excused absence, but it wasn't. We also do a training to doctors at CHOP and at other places to explain the type of note that needs to be provided. But one thing that I would recommend is that the 504 plan address non-attendance, address absences, and say that given the chronic condition of this child, these are the instances, this is the accommodation that should be made with regard to absences to ensure that there isn't an issue and that the child is not accumulating unexcused absences when they shouldn't be.
Very good. When you say an episode, do you mean a seizure?
Yes, I apologize. I was using that terminology and that may have been inappropriate, and
No, that's fine. A lot of people do. Let's see, my daughter has ADHD and epilepsy, and her school has said that she needed some help in math and wanted to put her in a Title I math, and had emailed the Title I teacher to see, and she said she would put her in a Title I, and just found out this week that she's not been in that math class. Was told January that she would be. So apparently they're telling this mother one thing and they're not following through. What advice?
yeah, so first I would suggest that I don't know, and I apologize to be answering in this way, but I have a lot of questions about whether the child may need to be evaluated for special education and whether the parent might think that that's appropriate or not. Number two, if they are providing the additional math support, obviously it needs to be provided, and they need to be providing you with notes to document that that's what they're doing. So I would ask for education records at this juncture to find out what is going on. And if they verbally said that, it's important for you to document this. And I would do it through email and explain that you were told in January, which was probably in writing, to explain that that has not occurred and that has impacted your child and what the impact has been.
School nurses use IHPs often. How do they fit in with all of this?
Well, the legal document is really the Section 504 service agreement. So that should really be what is driving and what it can be utilized in terms of the legal document to ensure that the child's rights are enforced. So I guess can you explain, and maybe you can, Mary, a little bit more about how IHPs are used?
I'm not really familiar with IHPs. We do 504s and IEPs. IHP, I'm not really familiar with that. Maybe Teresa, if you could.
Yeah, if there's a
tell us
follow-up.
A little bit more about that. Okay, these are like instructions for teachers. Okay, so they're instructions for teachers.
Yeah. Again, I would put it into I think it's important for families to know what their rights are, for school districts to understand what their duties are as well. So it should be in a 504 plan. It should be in that legally enforceable document. I would recommend that parents understand that they can ask for that evaluation and that they can get it in a 504 plan. I think that in many instances, parents are not aware of their rights under Section 504, or what is a qualifying disability, or what the process is and how these rights can be enforced. So I do think it's important to raise those issues with the parent and also raise them with the school district. In addition to trying to identify students who may need a 504 plan, the school districts also have a right to notify everyone of their policies with regard to non-discrimination. And the fact that 504 exists, it should be on their website, it should be in documents in the beginning of the year where they've informed parents and caretakers of what the rights of the children are. And that's embedded in the law. It's also in OCR decisions and in court decisions. So there was a question in here. I work in school with students with many disadvantages. The families do not know their rights. how do you suggest educating parents? And I do think that it's the duty of the school district to educate parents about it. I would also recommend Patan is a wonderful resource in Pennsylvania. They have a lot of webinars that are available. They'll also come into schools and do trainings for school personnel as well as for parents on these issues. I would recommend there. The Peel Center is another place that does trainings on 504. So I do think it is. We also do know your rights trainings when requested. So I do think it's important to get the word out.
Right. And dealing with epilepsy, some of my coworkers and I do go into schools with families and do the IEP and the 504. And we found that the parents are being told one thing, this is how it has to be. And we question it, like, no, don't settle for that. I went to one where the principal said the little girl had to sit on a curb in the playground because she was not allowed to play. And he really wanted her to be homeschooled because their steps had metal and he was afraid of the liability. But I pointed out that it was a handicap accessible with an elevator and she didn't need to take the steps. And he said, well, we'd have to have somebody with her. Exactly. Then you provide somebody to be with her on the elevator. Don't take an answer because they're trying to cut corners and they don't want to have to provide all of these things that you are deserving of.
Right.
So if you have a child, especially with an epilepsy diagnosis, contact us. We'll go with you to the school and we'll make sure that you're getting the rights that your child needs. Or anybody that has a diagnosis, wants to talk to us, that's fine. Now, do all children...
these other questions pretty quickly. Do all children with the diagnosis of ADHD qualify for an IEP under OHI? No. It depends on whether they need specially designed instruction for that ADHD. Some children do, some children do not. So it's a matter of the evaluation by a certified school psychologist making a determination as to whether the child needs specially designed instruction on that basis. Many do, some do not. So it's an individual decision, so I can't say that it's always one or always the other. Some children can need specially designed instruction and others need accommodations, which might be being in front of the classroom, etc. A lot of it depends on how the child is doing and what is working and what would work best for the child. And if you have an evaluation under IDEA that says you're not that the child does not qualify, you have a right to ask for an independent educational evaluation, an IEE, whereby a different person outside of the school district would make a determination as to whether the child is eligible or not. Can you provide information needed to set up a time to have someone visit the classroom?
We can do that. If you just give us your information, we will set up with you if that's the training that you want. I think that's maybe what they're talking about. And the next one is interested in having their staff educated. We can do that also.
Great.
Autistics emotional support school, but they have seizures. So we can help in that part.
And we're happy to do legal trainings, know your rights trainings if you contact me. I have my contact information on the last slide.
Very good. Some parents even want a copy of embedded in the IEP. The IHP is an individualized, okay, we went through that.
Yes, the individualized healthcare plan is not a legal document, but it could be something that is incorporated into a Section 504 plan or which becomes the 504 plan and the legal document that has to be signed by the parent. And it can be something that is a part of an IEP.
Okay, Irina put her information to contact us.
But importantly, just to underscore, an individualized healthcare plan is a treatment plan only. So it is not it's really not addressing how are you ensuring equal access to the curriculum, to learning for that child? How do you ensure it? Because it's actually too narrow. So you want to make sure that you have other accommodations as well.
That would only be for their meds or the health thing. They need to have with that IEP or the 504.
Well, a
Uh,
504 plan, and again, the IEP is more narrowly defined for the child who needs the specially designed instruction.
You mentioned a section of 504 is going under revision. Can you explain what that means?
Yes. So at the federal level, the 504 regulations are actually going to be revised. So we provided comments that I'm happy to share with folks on the advocacy side. If there are ways that you think 504 can be strengthened, and we believe that there are ways that it should be strengthened. Number one, that we need timelines to finish an evaluation to make sure that it's implemented in a timely manner. Number two, that we need to ensure that there are better protections for children who may be discriminated against. So, for example, like the IDEA, which has specific timelines and definitions of how you cannot be subject to school discipline, et cetera, we believe that that's important to have for children who have 504 plans. We want to make sure that children are accommodated in school and that the same protections that are in place in many ways for children who have IEPs because of the prescriptive nature, that more prescriptive language would also apply to 504 plans so that they are effectively implemented in a timely manner.
Okay, Maura, this is interesting. What about a field trip? The son is 8 years old and he has seizure diagnosis, but they won't allow the mother to go with him and say she needs to provide a qualified nurse to go with him on the field trip. What options does she have?
There are children who have seizure diagnoses that are able to go on field trips. There needs to be someone who is trained to be there. That in some cases it's a parent, in some cases it's a staff member who's trained, but I have not seen this where they're requiring a qualified nurse in order for the child to participate. Again, I think I'll look at the case law on this, but that would be a deprivation of equal access to a school benefit and activity that's being provided. I have heard this with my daughter having type 1 diabetes. There are many things that they would say, oh, well, she can't go because of risk factors. Again, that is discriminatory and there are ways to challenge that. But we have to find an accommodation that will effectively serve the needs of the child and ensure their safety and health.
And we just have other comments and a lot of thank yous. And Rena has put your information there. So any other questions? Okay, Maura, thank you so much for all this great information. It's really good. Nurses may be required on field trips for medication administered. We send them out in the field trips. Some schools may, but a lot of schools don't, and they have stopped children from going on field trips. So it depends, I think, on the school district or what the school has available.
Well, there have been some changes over the years, for example, with type 1 diabetes about who can administer medications, and there have been some changes to the regulations on that. But again, we want to ensure the safety of the child, but there are ways to do that.
So Rena, do you want to put up the post test? And if everyone would just take a few minutes to answer this. Hopefully what you've learned tonight will change your answers to the correct ones. There's only 4 on this. And we do want to thank our speakers. They were excellent tonight. I learned so much. And I think all of our attendees also had great comments. I'll give you a few minutes to finish this up. And when you're done, you can just log off and have a wonderful night. And we look forward to seeing you at some of our upcoming programs and events. And feel free to contact either of our speakers or us for any additional help. The test is up. If you don't see it, don't worry about it. Okay, thank you, everybody, and have a great evening. Good night.